Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. Today's talk is going to be about orthodontic diagnosis and treatment planning, and our reference is going to be Chapter 7 from An Introduction to Orthodontics by Simon Littlewood and Laura Mitchell, 5th edition. Okay? Now, as you can see, this chapter includes the general objectives of treatment, orthodontic treatment, how to formulate problem lists, aims of orthodontic treatment, skeletal problems in specific, and treatment planning, and then basic principles in orthodontic treatment planning. This part here already covered, space analysis has been already covered previously, and the valid consent, I think, also covered in another course. So we will be giving, after this, we will be giving an overall examples and cases after that. Now, it's very important to know that the orthodontic treatment planning is a complex area. And to be able to do so, to do a proper planning for a certain malocclusion, it's important to have the basic knowledge, okay? You will notice that this lecture is mainly pulling out all the knowledge that you got from your previous lecture and just organize them and use them. So I'm trying to teach you how to use this knowledge to build up a proper treatment plan and after reaching the accurate diagnosis. Okay. So at any part of the lecture, if you feel that you're lost, that means that you need to go back to that basic lecture to review. You need to have, as we said, the knowledge of normal growth and development, growth of the occlusion, fish and dental aesthetics, the lectures that you took about extraoral examination, intraoral examination, cephalometric analysis, space analysis, and extraction decision, of course, different appliances, functional appliances, removable appliances, fixed appliances, and their indications. Knowledge about retention, risk and benefits of treatment will be covered in your 5th year, but here we're going to talk about the basic principles, okay? What we mean by saying orthodontic treatment planning is that at the end, you need to decide, should I treat this case or not? And if I'm going to treat it, should it be to the ideal or a compromised treatment plan? And then you need to answer these questions. Do I need to extract it or not? If not, justify how you're going to provide space to correct the malocclusion. What type of appliance do I need to use? And this will depend on the amount of tooth movement, type of tooth movement, any associated growth modifications, etc. The anchorage demand, you need to specify your anchorage demand and how you're going to manage this anchorage. Buccal segment relationship at the end of your proposed treatment is very important. And of course, it should be either class 1 or full unit class 2 or full unit class 3 or accept the initial buccal segment relationship. And usually this is in compromised cases. And of course, you need to decide on the retention, duration, appliance. All these questions should be answered before you even start your treatment, okay? So to be able to formulate your treatment, it's important to have all these basic knowledge. Now, the general objectives of orthodontic treatment is to achieve optimal aesthetics, oral health, function, and stability, okay? We should never compromise oral health or function. So we cannot end with our treatment having premature contact and mandibular displacement, for example. This is not acceptable. For example, at the end of the treatment, I cannot have gingival recession due to severely proclined incisors, right? I cannot end up having a scissor bite with improper occlusion, okay? So we should never compromise dental health or function. On the other hand, sometimes we cannot create the ideal aesthetics and the most stable results. So we can compromise these two aspects, but the patient should always benefit from the treatment. So I cannot leave the patient worse off at the end of the treatment. Okay, when we use the word compromise, that means there are certain features of the malocclusion that could be corrected and other features that will be accepted. Compromise doesn't mean that I'm gonna cause harm to the patient. Always the benefit should outweigh the harms and the risks. Okay, otherwise, it's not justified to start treatment. Do not treat the patient. Okay. And if there's any aspect that is going to be compromised in terms of aesthetic and stability, it should be thoroughly discussed with the patient with different options and explaining all limited treatment objectives. So what are we aiming for? We need to reach to a problem list, okay? And then this problem list, we prioritize it and we reach our aims of treatment. Then, based on the aims of treatment, I decide on my treatment options. I could have plan A, B, C. I could use this appliance or that. I discuss this with the patient. I get a valid consent. And then after that, I have my definitive treatment plan. Right. Problem list. Where do I get my problem list? Problem list is derived after a proper collection of information. Okay, we will talk about this. So we need to know what's the problem the patient is presented with and come out with our problem list and proper diagnosis. I need to know why this happened. I need to understand the etiology. I need to know what can I do to correct these problems. I need to reach my treatment objectives. And after that, I need to know how am I gonna do this, my treatment plan. And as I said, during our treatment plan, you need to answer the following questions. Shall I treat or not? Ideal or compromise? Extract or not? What about anchorage management? What type of appliance do I need to use to reach and fulfill my treatment objectives? Timing of treatment, should I start now or should I delay the treatment? Treatment duration and prognosis according to the case. Retention and stability, again, based on how far did you move the teeth and the type of tooth movement, and the occlusion at the end of the treatment. So the first thing, as we said, we need to develop our problem list. I need information. This information I can get from interviewing the patient, taking proper history, extraoral, intraoral examination, and filling my examination form, and then having any diagnostic records accordingly. I might need study models, colored photos, cephalogram, OPG, sometimes comprehensive CT scan. It depends on the case. Everything I take, it has to be justified. I need to give a good rationale for exposing the patient to radiographs, for example, or the patient is paying extra for a comprehensive CT scan or for study models or photographs. I need to make sure that this information is beneficial for the patient in terms of developing a proper diagnosis and treatment planning. After I collect all this information, I analyze it, as you remember from your cephalometric analysis lectures, lectures related to space analysis, and of course the intraoral, extraoral examination lectures. And after that, I come out with my problem list. Anything on my examination sheet that deviates from the normal is considered a problem. Okay, I have two types of problems: the non-orthodontic problems, which is the pathologic problems, and the orthodontic problems, which is the developmental problems. The pathologic problems include caries, calculus, plaque accumulation, periodontal problems, broken restorations, a tooth with poor prognosis, gingival recession, etc. So everything that is not related to the occlusion. Okay. And then after that, we come to our developmental problems, which is the orthodontic problems. So anything that deviates from the normal should be on my problem list. And then after that, I take this problem list and I decide each problem on my list. Can I correct or should I accept because, for example, it's really mild, or because the patient is refusing surgery? Or maybe I have limited orthodontic aims related to patient's medical condition, for example, or I can monitor and review. So I can accept, treat, monitor, or review these features. So each problem on my problem list, I have to make a decision. This means that I'm trying to prioritize my problem list and reach to my treatment aims. After I reach my treatment aims, then I can define and I can formulate my treatment plan. Okay, so pathologic problems are related to, as we said, caries, periodontal diseases, etc., and these problems should be treated. So I said that each item on my problem list could be accepted, treated, or reviewed, except for the pathologic problems. It's a must. It is a must to treat and manage these problems before we start any orthodontic treatment. And then the developmental problems are part of my orthodontic problem list where I need to make a decision regarding their management. Right, so this is an example of a patient with poor oral hygiene, plaque accumulation. So this should be part of my non-orthodontic problems. As you can see here, badly destructed lower left 6, active caries on the lower right 6, gingival recession, plaque accumulation, poor. So all these should be part of my non-orthodontic problem list. And then we come to our orthodontic problem list, right? How do I organize this list? There are 3 different ways to do it. The classical way that we actually apply in our clinics, and you're going to be applying this during your next year when you examine clinical cases, and it is following the etiology. So we start, of course, with the skeletal problems in the anterior posterior vertical transverse, and then soft tissue problems in the anterior posterior vertical transverse, and then dental problems anterior posterior vertical transverse. And this is covering all issues. Okay. Another way to organize our problem list is based on patient's chief complaint. Okay. What are they concerning about? So maybe the patient will come with severe class D and their chief complaint is a rotated upper left lateral. So it has to be addressed. Okay, it has to be mentioned. Or we can follow the Ackerman and Prophet list of problem. We will come to this now. So I'll just want to show you the examination form that we will be using later on 5th year clinics and sessions. And as you can see, this is the information related to the history taking and interview, extraoral examination, intraoral examination, and occlusion. This is the first page, so you write down everything. So even if the patient has class 1, I write down class 1. So even if it's normal, I write it down. If the patient has a normal symmetrical face, I write it down. Incompetent lips, I write everything down. So the examination form, you record everything as you see during the examination. And then space condition and the space analysis and alignment of teeth, you actually write beside everyone the lower labial segment, the lower buccal segment, the crowding or spacing, and the alignment of teeth. When you finish the examination, you need to write down your problem list. And the difference between the examination and the problem list, we only mention the problems. So I cannot, for example, say in the non-orthodontic problems, good oral hygiene. Well, this is not a problem, or good tooth quality, or no fillings. This is not a problem, okay? And the skeletal here, I need to write down, for example, class 2 skeletal pattern. If it's a class 1, I don't write it down because what is considered normal is to have a class 1 skeletal pattern. If I have average lower facial height, I don't write it down, for example. If I have increased Frankfurt mandibular plane angle, increased maxillomandibular plane angle, I write it down. So I have to write anything that deviates from normal. And I have to decide on the etiology. Okay, I need to decide why this happens. So for example, the patient has class 2 skeletal pattern because of a retrognatic mandible. How do I know this? During the clinical examination and based on the cephalometric analysis, this was confirmed. Okay, so I write down etiology that is related to this specific patient. I don't write a huge list of etiological factors that are possible. We're talking about that specific patient. Soft tissues, for example, the patient has lower lip acting behind the upper incisors. So we write down lower lip acting behind the upper incisors. Why? Well, because the overjet is increased, because the patient has high lower lip line, for example, class 2 skeletal pattern. So whatever that is related to the patient should be written down. Dentally, you need to write down the dental features classified according to the dimensions. So we start with the anterior posterior, vertical, and then transverse dimension, and you need to mention the etiology. Okay. Now, based on Ackerman and Prophet, there are 5 steps to formulate your problem list. The first one is to evaluate facial proportions and aesthetics. And then number 2 is to look at the alignment and space condition and symmetry of the arches. And number 3, 4, 5 is looking at skeletal and dental features in the transverse plane, anterior posterior plane, and vertical plane of space. Okay, in the 3 dimensions. Now, the problem list that is used in chapter 7 that I gave you as a reference actually modified Ackerman and Prophet and actually added patients' concerns as the first item. So we have 6 items here. The first thing is the patient's concerns, and then facial and smile aesthetic, and then alignment and symmetry, and then the 3 dimensions related to skeletal and dental relationship. Okay, so we're going to talk about these features in details, the problem list, this problem list in details, but at the end, we're going to use the problem list related to the etiology. So we're going to use our order of problem list related to non-orthodontic, as we know, and then after that, skeletal, soft tissue dental. Okay. So even if I'm talking about this problem list, some parts will apply actually to our problem list in terms of features and deciding on what's the problem. Patients' concerns is extremely important. Unfortunately, in orthodontics, treatment success is very much relying on patients' cooperation and compliance. Okay, if the patient is complying with your treatment, then you will have a successful end result. Okay, so this is why it's important to, from the start, talk to the patient and understand exactly why they want the treatment. What is their chief complaint? What are their expectations? And what is their motivation? Because we know that we have internal motivation and external motivation. Internal motivations are those patients who are demanding treatment for themselves. They want the treatment. So this is good. Internal motivation is strong, is good. This will give you a patient who will be complying, cooperative. External motivation are patients who comes to satisfy other people, for example, to satisfy their parents or their partner. These are difficult patients because at any point of treatment, they might lose their motivation and they will start to cause problems, and they will lose cooperation and have poor compliance, and you will end up having compromised results accordingly. Now, a patient that his chief complaint was fulfilled will be satisfied. If it wasn't fulfilled, they will never be satisfied. Okay. And how can I understand patients' chief complaint? By taking history, talking to the patient, taking information from the patients. Why are you visiting us? What's the problem? I can give the patient a mirror and ask them to point out the features of their smile or dentition that they don't like and they want to change. Okay. Now, most of the time, their chief complaint is realistic, so they can point out at a certain problem and it's there, so it is realistic. So this is good. But sometimes their patient's chief complaint and expectations are unrealistic. It doesn't make sense. For example, a patient who comes to your clinic with severe crowding, so both canines are buccally excluded from the arch. One of them is erupting, the other is partially erupting, and then the upper right 5 is palatally displaced, and the patient is refusing extraction. So they want to have a whole smile with no extraction. So this is unrealistic expectations at the end of the treatment, for the end of the treatment without extraction. Another patient who presents with severe class 3 malocclusion and they want to improve their profile and they are refusing surgery. So again, this is unrealistic. Or patients with microdontia, generalize the spacing, and you offer them orthodontic treatment in addition to restorative treatment so as to build up the teeth and get a good smile. and the patients are refusing restorative treatment. They want to have, again, Hollywood smile with no restorations. This is unrealistic. Your job is to talk to the patient, educate them, show them photos, other cases, show them what we can do and what we cannot do. Maybe the patient will understand and they will modify their expectations and their concerns, and then we can go on with the treatment, have a proper consent from and so on. But if they don't actually change their way of thinking, do not treat this patient because they will never be satisfied because you will never be able to fulfill their concerns. Okay, so do not treat these patients. It's important to explain to the patient that there are certain features that are considered normal and others that are considered part of the malocclusion. So for example, a patient who has normal overjet and they're asking you to reduce the overjet to reach edge to edge, it's important to tell them that a normal overjet of 2 millimeters having the upper incisors in front of the lower incisors is considered normal. Edge to edge is not considered normal, okay? As I said, successful orthodontic treatment, we need the patient to be on board. They should understand what's going on. They need to understand what we cannot do, what we cannot do, and we need to reach our treatment plan with the patient's consent on each part of it. Again, if the patient is not really willing to cooperate, they are not willing to maintain excellent oral hygiene, they are not motivated, okay? Again, don't start treatment because this will fail. The treatment will fail if the patient is not willing to cooperate with your instructions, with the wearing the appliance, wearing elastics, coming to the appointments, brushing their teeth, then do not start the treatment. Right. So patients' concerns, for example, let's give you examples. So this patient comes to our clinic and the chief complaint is spacing. And he said that they told me that my lower jaw is retruded. If you look at this, well, actually it's realistic. His lower jaw is a little bit retruded. The patient is having mild skeletal pattern and there are spacing between his teeth. So can we correct this? Yes. We can correct the spacing, but if the patient is beyond the growth modification, we might need to accept the skeletal pattern or wait until the patient is an adult to go for orthodontic surgery, okay? But his chief complaint is realistic. Now we come to this patient here. This patient's chief complaint is proclination of upper and crowding of lower. So if you look at the lower, they are crowded, so this is realistic, and she's right. But the upper incisors are not proclined. Actually, they are not proclined. If you look at the cephalogram, they are almost within their normal inclination. So it's important to discuss to the patients that the upper incisors are at their normal inclination, and the patient feels that they are proclined, maybe due to the deep bite, relatively due to the crowded lower teeth. So if we align the teeth, then relatively, let's say that the patient will be satisfied. So it's important to tell the patient that we are not aiming to retrocline the upper incisors. We're simply going to procline the lower incisors and maintain the normal overjets and maintain everything else. Okay, because it's not realistic to retrocline upper incisors that are of normal inclination. They are almost 110. And for the Jordanian population, the normal, I think, 111 or so. So we are within the average limit. This patient here, his chief complaint is proclination and crowding of the lower anterior teeth. So if you look at the lower anterior teeth, yes, they are crowded, but actually they are not proclined. So if we look at the angle of the lower incisors, it's almost upright. They are not proclined, but maybe the patient was not able to explain what he's really concerned about. So we had to show him photos, we had to talk to him, we had to get a surgical consultation to educate the patient that the problem is not with the lower incisors, the problem is with the lower jaw. The whole jaw is prognathic, increased vertical proportions. The AMB is -4. So if we cannot, not part of our treatment is to retrocline the lower incisors because they are not proclined, okay? We can align them, we can prepare the patient for surgery, and then we can go for orthodontic surgery. Otherwise, align and level and stop. We cannot retrocline them further, as the lower incisor, as I said, are almost upright. Okay, so a little bit of education to the patient, and the patient, most of the time, they will understand the problem and they will cooperate with your treatment. So this patient, we are preparing him at the moment for orthodontic surgery. Right, facial and smile aesthetics is next. What should be on my facial and smile aesthetic in terms of problems? Well, we need to look at facial symmetry. If there is asymmetry, I need to record it. Sometimes we look at the anterior, posterior, and vertical facial proportions. Most importantly, soft tissues. We need to look at the lips. Prominence in relation to the upper incisors. We need to look at the lips thickness, competency, lip line at rest, lip line on activity, and smiling, how much incisors are showing on at rest or smiling, and the pattern of swallowing. These are all important to record as features related to aesthetics. Nasolabial angle is important to record. We know the average is 90 to 110. So is it obtuse? Is it acute? If it's average, I don't have to mention this. I don't have to put anything that is normal on my problem list. The labiomental fold sometimes could be prominent or could be flat. So I need to mention this. And of course, these problems could be recorded during clinical examination and also later on using the lateral cephalogram after analyzing it and using the colored photograph. So we can sit and look further for these features. Now, straight teeth alone cannot guarantee good aesthetics. The position of the teeth within the face in relation to the soft tissues very much affect the aesthetic and should be considered. Okay, so this patient, for example, at rest, we have about 3 millimeters of incisal show. On smiling, we have full clinical crown plus considerable amount of gingiva, and this is not normal, so this has to be recorded. Now, the perception of facial aesthetics actually is different, and it is really affected by culture, affected by personal traits, and affected by some social and fashion trends. Just to give you an example, the recent trends toward more protrusive profiles, where the people are demanding proclining upper and lower incisors to have this full, youthful appearance profile. Sometimes this is not realistic. Sometimes this is not possible because we have the risk of proclining upper and lower incisors into an unstable position. We might end up having compromised gingiva cover with the risk of gingival recession and bone dehiscence. Incompetent lips as well as unaesthetic results. Excessive protrusion can cause unaesthetic results. So it's important to balance between these trends, the patient's demands, and what should be done for the patient from an accurate, let's say, tooth movement and treatment plan. Protrusive profile. So this is a protrusive profile. You can see this is a protrusive profile. And on the other hand, we have retrusive profile. Okay. Again, patients with retrusive profile, if the patient has no crowding or minimal crowding, let's say mild crowding, it's better to avoid extraction with patients with, let's say, flat profiles, okay? It's not true that if you extract in patients that you will flatten the profile, but if you make the wrong decision, so if the patient, as we said, has mild crowding or well-aligned teeth and you extracted teeth, then this is the wrong decision. You will end up compromising the nasolabial angle, compromising the profile, compromising the soft tissues in the lip support. So this is an increased nasolabial angle. It will increase further. Okay, the lips are already thin and retrusive. They will get worse. Flat profile, it will get worse. Okay. And here we're talking about wrong decisions of extraction or excessive retroclination of the upper labial segment, because this will flatten the profile. Okay, so if the patient has increased nasolabial angle, large nose, retrognathic mandible, we need to avoid retroclination of the incisors. okay, because it will worsen the profile. So it's important to consider the anterior-posterior position of the incisors and their effect on soft tissues and aesthetic profile. Now, sometimes the facial aspects are too severe for simple orthodontic tooth movement, and we need to have a combination between surgical and orthodontic correction. So, for example, a patient with such severe gummy smile, we need to have a combination of orthodontic treatment and surgical correction of the maxillary vertical excess. Okay, so sometimes we need to discuss with the patient of treatment options. Now, let's give you an example about facial and smile aesthetics. So this patient here, the patient, if I want to describe her facial aesthetics, I need to say that there is no clinically significant facial asymmetry, okay? And this is part of my exam. I write this on my examination sheet, but not on my problem list because this is normal. No clinically significant facial asymmetry, right? So this is normal. Anterior-posteriorly, the patient is showing class 2 skeletal pattern with convex profile, so this has to be part of my problem list. Vertically, the patient has increased vertical proportions, high Frankfurt mandibular plane angle, and this is due to posterior growth rotation. The lips at rest are incompetent. The lip line, the lower lip line is low, and incisal show at rest is about 9 millimeters, and on smile there is about 8 millimeters of gingiva show in addition to the full clinical crown. So this is not normal, so we have to mention this on our problem list. Lips are of normal activity and normal thickness. I don't have to mention this during my as part of my problem list. The nasolabial angle is average. Again, this is normal. And the labiomental fold is reduced. You can see that the labiomental fold is almost flat because of the incompetency of the lips and because of the increased vertical proportions. Okay, actually, the patient's chief complaint is my canines are away from other teeth. Actually, they are vertically away. So the patient has realistic chief complaint. And nevertheless, we have to educate the patient that she has a vertical problem and this can only be treated with the surgery. And the patient has the right to choose to go through surgery or not. But it's our job to educate the patient that this is an option. So we usually have plan A, plan B, plan C, etc. And we need to discuss the risks and benefits, duration, cost, and everything with the patient in order to choose the best treatment for them. So this is an example of how to describe the facial aesthetics and smile. Now we're going to talk about alignment and symmetry within each arch. Okay, so the process of analyzing the space required to correct the malocclusion is called space analysis. Okay, not only space is required to relieve crowding, but space is required to correct other features of the malocclusion. For example, if I want to procline or retrocline the incisors, this will affect space condition. Expansion will affect space condition, derotation of posterior teeth, flattening curve of spee, also distalization of the molars, correction of center line, correction of molar and canine relationship, all will have demands in terms of space analysis. And this should be properly documented and recorded because this will affect on our treatment plan later on. Symmetry of the arches also has to be recorded on this list. So we can have the transparent ruled grid. We put our study model and we can look at the symmetry. Nowadays, this could be done digitally using certain softwares. So for example, let's look at this lower arch. It is tapered shape with moderate spacing anteriorly. We have missing second premolars with ease, retained and submerged. The lower incisors are proclined. So this is how we describe the alignment and the space condition for this lower arch. This upper arch, for example, is a V-shaped collapsed upper arch. There is moderate crowding of -5 millimeter. There are retained deciduous teeth, so we have retained C in the upper left quadrant, we have retained D in the upper left quadrant, and we have active caries on both sexes. Actually, this should be on the non-orthodontic problems, the pathologic problem list. So if we exclude these two retained deciduously, then the crowding will be -5, which is moderate crowding. Buccally displaced left canine. The left canine is buccally displaced, and first premolar as well. Lingually displaced second premolars on both sides. Both lateral incisors are slightly palatally displaced. And as we said, there are caries on the first permanent molars. Okay, so this is how we describe the alignment of the of each arch. Now we come to the skeletal dental relationship in the transverse plane, in the anteroposterior plane, and in the vertical plane. Okay. Now the aim is to describe the occlusion, and the etiology of the occlusion is to reach a proper diagnosis. Is the problem dentally only, or are there certain skeletal patterns that are contributing to the etiology? Because if it's only dentally, then the treatment is usually straightforward, easy, with predictable results and stability. But if the problem, part of the problem is a skeletal, then the more difficult the case is. Because we need to either modify the skeletal pattern or correct it by surgery, or accept it and camouflage the dental relationship around the skeletal discrepancy. Right, so in the transverse dimension, what do I need to mention in terms of the skeletal? Of course, the symmetry of the face and the symmetry of the jaws. In terms of dental, the transverse relationship includes the center line and includes posterior crossbite. So I need to list this if present in this list, in this part of the list, let's say, under this subheading. Now, if there is crossbite, I need to know the etiology of the posterior crossbite. Is it skeletal or is it dental? If the teeth are leaning inward, that means that most probably the crossbite is due to dental etiological factors. If the teeth are leaning outward, that means that we have narrow maxilla and the etiology is skeletal. So as you can see here, we have a normal transverse development of the maxilla, and the teeth are leaning inward. So most probably the crossbite is resulting from dental factors. Here we have narrow transverse maxilla. It is narrow, and we have teeth that are leaning out, and the etiology is skeletal factors related to narrow maxilla. There are certain tables that will give you the normal intermolar width, intercanine width, and will based on gender, males and females, and it will give you a clue of any problems in the transverse dimensions. Sometimes the problem is not only related to the maxilla, sometimes the mandible is well developed, for example, and it's expanded, or maybe it is small and narrow, and it can contribute to the transverse discrepancy. So this is the maxillary arch, the mandibular arch, and the intercanine width, interpremolar width, and the intermolar width, okay? Males and females. Now, let's take an example about the transverse plane, the skeletal and the dental. What can we mention about this patient here? You can see that the patient has facial asymmetry, okay, where the chin is deviating to the right and the nose is slightly deviating to the left. So the patient has facial asymmetry, so we have to describe this. Now, also transversely is related to the center line. The upper center line, as you can see here, is correct within the center line of the face, but the lower center line is shifted to the right 2 millimeters. In relation to the crossbite, we have crossbite on the upper left first and second premolars, and it's mainly due to crowding, not due to skeletal factors. It's mainly related to crowding. Right? I'm not talking about the anterior crossbite. I'm talking about, because this is transverse relationship, I'm talking about the buccal segment crossbite. Now we come to the skeletal and dental relationship in the anterior posterior plane. Okay, as you remember, this is following the Ackermann and Prophet list of uh, problem list modified according to chapter 7 that you have. So in the anterior posterior, the first thing on our item is the skeletal pattern. Is it class 1 or 2 or 3? If it's class 1, I don't mention it in my problem list because this is normal. And then I need to mention the convexity of the face. Is it convex, straight, or concave? And after that, I move to the dental features that are examined in the anterior posterior dimension, starting with the overjet. Is it normal, average, 2 to 4, or is it reduced, edge to edge, reversed, or is it increased? I need to describe the canine relationship on the right and the left, the buccal segment relationship on the right and the left. Is it class 1, class 2, class 3? Is it half unit, quarter unit, full unit, etc.? And the skeletal pattern can be confirmed after cephalometric analysis. Again, let's take this example. Now I want to describe the skeletal and dental relationship in the anterior posterior plane. Okay, anterior posteriorly, the skeletal is class 3 skeletal pattern. The profile is concave. The incisors are class 3 with reverse overjet of -2. There is anterior crossbite, which is part of the anterior posterior relationship. There is an anterior crossbite extending from the upper left 2 to the upper right 3. The canines are class 3 half unit on both sides. The molars are class 3 half unit on both sides. Okay, so this is describing all features of the malocclusion in the anterior posterior dimension, skeletal and dental. Now we come to the vertical. What are the problems that could be mentioned here? Extraorally, problems related to the anterior lower facial height, maxillomandibular plane angle, Frankfurt mandibular plane angle, and vertical excess of the jaws. Okay. And dentally, the main feature is the overbite. Okay. And the overbite, we can have an anterior open bite. This is an anterior open bite. We can have deep overbite, and we can have posterior open bite. Okay. So I need to describe the vertical problems dentally, intraorally. Of course, cephalometric analysis can help us to confirm such features in relation to the maxillomandibular plane angle and graft rotation. Okay, let's go back to our patient. An example, how can I describe the skeletal and dental relationship in the vertical dimension? The patient has average anterior lower facial height, so I don't mention this in my problem list. But the patient, as you can see here, has increased Frankfurt mandibular plane angle and increased maxillomandibular plane angle. The vertical relationship intraorally, the overbite is reduced and incomplete. The overbite is reduced and incomplete. And that's it in relation to the vertical proportions. Now, so this is the modified problem list based on the chapter that I gave you, starting with patient's concerns, facial and smile aesthetics, alignment and symmetry within each arch, and then the skeletal and dental relationship in the transverse, anterior, posterior, and vertical plane. Now, as we said, the problem list should include everything that deviates from normal. I don't mention the normal, but anything deviates from the normal should be mentioned in my problem list. After you complete the problem list, you start to prioritize the problems, think about the etiology, reach a proper diagnosis, and eventually think about how to correct these features, and before that, which features I need to correct, which features I need to accept and monitor. Okay, so this is a very important step in the formulating treatment plan, because if you understand the problem and the etiology, then you will reach a proper treatment plan for that specific patient. Okay. And in front of each item on your problem list, you have to write down the etiology. Okay, so going back to this guideline, let's say, I need to know what the problem is by having my problem list. I need to know why this happened. I need to understand the etiology. Okay, so let's move to the etiology. So this is my examination form, and this is my problem list, as you can see here. And in front of each problem, I need to know the etiology. It's important to decide on the etiology. And then after that, I need to think about the problems, the items in my problem list. Do I need to correct? Maybe it's too mild, as we said. Maybe the patient is not really concerned about this feature. Mild class 2 skeletal pattern, the patient is happy with his profile. Then in our treatment objectives, we write here accept. If the patient has moderate class 2, they are still growing, then I can write here modify class 2 skeletal pattern to class 1. Correct class 2 skeletal pattern to class 1. How? Down here, I write how. Type of appliance, for example, functional appliance. So I'm aiming to correct the skeleton. So let's take this example about how to develop our problem list. So this is a male patient, 14 years old. His chief complaint is the upper right central incisor is out. So if you look, it is out actually, but in occlusion, it looks like it has an average overjet and average overbite. But clinically and based on the patient's smile, it looks out because the rest of the teeth are actually in crossbite. Right, so what is the non-orthodontic problem? Multiple caries, okay? Multiple, nothing else. Acceptable oral hygiene, we're good. No gingival problems or periodontal problems. So basically, it's only the multiple caries. Now we move to the orthodontic problems. And we're going to use here the order of problems related to the etiology. So we're going to start with the skeletal in the anterior posterior, vertical transverse, and then soft tissue. Again, anterior posterior, vertical transverse, and then dentally, anterior posterior, vertical and transverse. Skeletally, if you look, although this view here with the patient raising his head looks like a class 3, but you can see that the radiograph shows that the patient has actually class 1 skeletal pattern. So we don't mention this in our problem list because class 1 is considered normal. And so this is the anterior posterior. The patient has in the vertical dimension problems related to increased vertical proportions, increased anterior lower facial height, Frankfurt mandibular angle, and increased maxillomandibular angle. So this is a vertical problem that we need to mention. Transversely, the patient has acceptable facial symmetry. Okay, so we don't mention this. Next is soft tissue. In the anterior posterior, soft tissues looks normal, nasolabial angle is normal. Lips are incompetent. Lower lip line is low, so we have lower lip line. And vertically, the patient has gummy smile. Gummy smile. Now, this is problems related to soft tissues. And as you can see, the labiomental fold is flattened due to the incompetent lips and the active mentalis muscle. Right. Now we come to dental problems. Dental problems, again, we need to look at the anterior posterior, vertical transverse, and then each arch alone. Okay, the lower arch and then the upper arch in terms of space condition and alignment. Right, so anterior posteriorly, if we look at the incisors, there are class 3 incisors classification. Overjet is only average on the upper right central incisors, otherwise it's minus 1 millimeter reverse overjet. We have anterior crossbite, and this anterior crossbite includes teeth that upper right 2, upper left 1, upper left 2. Now, in the anterior posterior, in the labial segment, we are finished. Now we're going to move to the buccal segment. Now, the upper right canine anterior posteriorly is quarter unit class 2. The upper left canine is class 1, so I don't need to mention really. The upper right canine is half unit class 3, molar relationship. And the left the upper left canine molar, sorry. So the molars on the right side is half unit class 3, on the left side half unit class 3. Right, so this is finishing the dental features in the anterior posterior dimension. We will move to the vertical dimension. In the vertical dimension, the overbite is reduced and complete. So reduced is a problem, right? Because we know that the average where the upper incisor cover about 1/3 of the lower incisor. Transversely, there are no cross bites buccally, but we have center line discrepancy where the upper center line is shifted to the right about 1 millimeter. Right. Now we're gonna move to the lower arch. In the lower arch, as you can see, all teeth are present 7 to 7, and there is mild crowding of 3 millimeters. And the upper arch, if we consider that this is the normal line that represent the normal arch for this patient, then the crowding is severe, 9 millimeter of crowding. And teeth present 7 to 7, yes, we have multiple rotations and multiple displacements. So for example, the upper left canine is mesiolabially rotated. The upper left lateral is distolabially rotated. The upper left central is buccally displaced. The right central, palatally displaced, and the right central is buccally displaced. The right lateral is palatally displaced. So we have multiple rotations and displacement of teeth. So this is mentioning all features of the malocclusion. Now we need to think about the etiology. Why this happened to this patient? So why we have multiple caries? Well, because of poor oral hygiene, sugary diet at a certain point of his life. Now it has improved, but some active caries are there. It's minimal. Okay. Now, skeletally, we have, as we said, increased Frankfurt mandibular plane angle, maxillomandibular plane angle, and increased lower facial height. Why? Because the patient has posterior growth rotation. You can see the divergence between the maxilla and the mandible. So there is a clockwise rotation if we look at the patient's cephalogram. So there's increased posterior growth rotation, and this is the etiology. The patient has gummy smile. Oh, sorry. The patient has, in terms of soft tissues, incompetent lips and low lip line. The incompetent lips and low lip line is related to the increased vertical proportions. And this is why, although the patient has normal activity of lips, they cannot meet at rest because of the increased vertical proportions. Gummy smile is related to maxillary excess, vertical maxillary excess. And this is why the patient has increased gingiva show on smiling. Right. Dentally, the patient has class 3 incisors classification. Most probably it is due to crowding and displacement of teeth. The same related to the reverse overjet, and the problem here related to premature contact and mandibular displacement. So we have premature contact and mandibular displacement, anterior mandibular displacement that contributed to the reverse overjet and the anterior crossbite. Okay, the canines quarter class 2 on this side. It's because of the crowding mainly affecting this lateral incisor. So crowding is affecting all teeth, but this lateral incisor is more severely affected. And part of the problem is that the canine has shifted mesially, ending with a quarter class 2 canine relationship. Right, so molars are class 3. On the other hand, half unit. Maybe part of the problem is anterior mandibular displacement. Anterior mandibular displacement could have contributed to the half unit class 3 molar relationship. Upper center line is shifted to the right, and this is part of the overlapping and the crowding. The lower arch has 3 millimeter of crowding, and this is related to tooth size, arch length discrepancy. This is the etiology. Okay. The upper arch has about 9 millimeter of crowding with multiple rotations and multiple displacements, and this might be related to, again, tooth size arch length discrepancy, in addition to premature contact and mandibular displacement that did cause the alignment of teeth not possible, because now the teeth are locked behind the lower incisors in a crossbite. Okay, understanding the etiology can actually help a little bit in deciding what to do, how to stop the problem, and what appliance we're going to use, and when to start the treatment. So lots of decisions will be based on when we understand the etiology of this malocclusion. Once we formulate our problem list, we understand the etiology, we need to have a decision for each item on our problem list. Should we treat or accept and monitor? As we said, non-orthodontic problems should always be treated. Okay, not to the using fancy, expensive restorations, but we can use permanent restorations until the end of the treatment, where we have the final occlusion, and then replace them with the crowns, for example, or modify them according to the final occlusion. Yeah. So once I decide my treatment aims, what to treat, what not to treat, as we said, then we have our treatment options. How can I achieve this? Usually have more than one treatment options, and we discuss this with the patient, and we get the consent, and then we end up with our definitive treatment plan. Okay, so just to remind you that this is where everything starts. We start by proper history taking, examination, and then analyzing of records, and end up with our list of problems and list of etiology. Okay, and each item on our problem has to be addressed here, and after that we need to think about how we're going to manage such case, and how can I fulfill my treatment objectives. So the next part of our lecture is going to be on formulating our treatment objectives, aims, and then ending up with treatment plan. And we will have some clinical cases as examples. Thank you for listening.